Hello, my name is Jae Kim. I am an undergraduate student here at Johns Hopkins University at the Department of Biomedical Engineering and the Functional Neurosurgery Lab. My main project is concerned with developing a semi-automated platform that will better assist clinicians, especially neurologists and neurosurgeons, in diagnosing and assessing the motor symptoms of Parkinson's disease. To give a brief introduction to Parkinson's disease and my rationale for the project is that Parkinson's disease, PD for short, is a progressive neurodegenerative disease due to the neural death in substantia nigra, which affects the basal ganglia pathway and ultimately leading to hallmark symptoms as bradykinesia, which is the slowness in movement, resting tremor, and muscle rigidity. So most of the symptoms are traditionally accessed by neurologists in clinics qualitatively from their either from their own expertise and experience through a rating scale called the UPDRS-3. But the outcome of the rating is highly variable between the raters themselves or within the same rater across different clinical sessions. So here my objective is to quantitatively collect and interpret the PD severity using computational modalities. So aside from normal clinic sessions, the UPDRS rating is also done intraoperatively during DBS, so deep brain stimulation electrode implantation surgery, to confirm the location of the electrodes in the appropriate basal ganglia structures, such as the globus pallidus or the subthalamic nucleus, and the preliminary stimulation settings, such as the stimulation frequency or voltage. However, similarly to the in-clinical sessions, the UPDRS ratings still themselves are highly susceptible, or even more so, to inter or intra-rater variability in surgical operations. So in order to provide more optimized feedback for the DBS parameters, an objective quantification method is necessary. As a candidate solution, we propose a novel wireless motion sensor called Leap Motion. The Leap Motion device has actually been around for a couple of years used in augmented reality applications in systems and gaming. Uh, so what it does is that it captures the XYZ 3D coordinates for the fingers and the joints, which ultimately comprises a hand, throughout the recording session. This would provide an avenue to extract the motion parameters of interest, which entails of the velocity, angle, frequency, while the patients or subjects are undergoing the UPDR-S3 task, which we can run through the pipeline that I have been developing to compare with the actual clinician rating. So one significant advantage of using the wireless device, in contrast to previous method proposed to quantify PD symptoms, such as the gyrometer or the accelerometer, is that it poses a minimal to no contact with the patients. So especially in a surgical setting where patient movement is already restricted, a wireless means such as using the Leap Motion device can minimize this hindrance with par performance as the previous solutions. So the left video is the 3D reconstruction of the hand after extracting the XYZ coordinates from the Leap Motion sensor. Uh, and the figure to the right captures the motion parameters that we have selected from our left video across time, such as the angle between the fingers formed between the index and the thumb, as the subjects are asked to perform this series of task batteries. All the results collected are from a single sample patients undergoing a DBS surgery and who are in baseline condition where no stimulation is yet to be applied. The purpose of the study is to assess whether Leap Motion wireless sensor is suitable to detect the hallmark symptoms of PD. For this study, our symptom of interest is bradykinesia, the slowness of movement, which can be tested across three main UPDRS3 sessions. The finger tapping task, the permutation task, and the palm grasping task. From here, I will cover the motor parameters of interest and the respective preliminary results. So starting from a finger tapping task, our pipeline detects the mean Euclidean distance between the thumb and the index finger, and the frequency between the two successive peaks of the distance. The frequency is calculated as the mean reciprocal of the time or the period between the two successive peaks. So our results so far have about 40 millimeters as the mean amplitude And as for frequency, we have 1.25 Hertz. The second task for bradykinesia assessment is called the Permutation Task. As you can see to the video to the left, it is like the name implies, the patient is asked to undergo palm supination and pronation. And our pipeline here is interested in extracting the change in angle on radians formed between the normal vector shown to the figure to the right and the vertical plane. Similarly, the frequency would be registered as the reciprocal of the time or period taken between two successive angular peaks. So the sample result for the angular disposition and change is shown to the figure to the left. So then the mean amplitude of this angular change was about 1.5 radians, and the mean frequency was about 1.78 hertz. So the last task for bradykinesia is called the palm grasping task, as you can see onto the video in the video to the left. Here, the pipeline calculates the Euclidean distance between the centroid of the palm coordinates and each of the four fingers, the pinky, ring, middle, and the index finger. And the mean frequency components were also calculated using the same measurements or method as the past two tasks. Here, our sample results show that we have the mean amplitude about 48.83 millimeters and the mean frequency about 0.83 hertz. Apart from the bradykinesia, our last symptom we looked into was the resting tremor. So in order to assess the resting tremor, we utilized a mathematical tool called the PCA, the principal component analysis, to extract the three PCA vectors that is most representative of the XYZ coordinates from the total of 22 spatial coordinates that originally compose a single hand. The main objective here is to undergo dimensionality reduction to extract the most meaningful spatial orientation that can holistically represent the overall movement of the hand. The reason being is that the tremor itself is not unidirectional or localized to a specific finger or joint, such as the bradykinesia and the previous EPDRS3 task, but rather the motion of the entire hand. So the PCA would provide us with the information that fully captures even the minute hand movement tendencies, which we can then translate as tremor. Uh, then we observe the oscillation of the angle formed between each of the PCA vectors and the vertical axis of the tremor, which I will show in the figure in the next slide. What the pipeline will do is that it will calculate the double derivative, which is essentially the angular acceleration, following the frequency decomposition to identify the representative tremor frequency. Here, the video on the left shows the change in the PCA vector's orientation relative to the vertical axis from a patient who is undergoing a tremor during the DBS surgery. Um, the right figure shows the results post-frequency decomposition of the angular change, which its maximum, as you can see, lies on a little less than 5 hertz. Uh, so this and since the typical resting frequency range for PD has been known to be around 4 to 6 hertz, so this range covers our extracted sample value of the resting tremor, and the PCA analysis can provide some insight into quantifying the tremor itself. So past studies have suggested that our quantified motor parameters well align with the baseline PD symptoms. So for example, the previous two papers have shown that the frequency for the finger tapping task and the palm rotation task, and our experimental results are well aligned with this range from the previous literatures. Um, Here our results further substantiates the fact that using a lead motion sensor or the wireless sensor as a whole is indeed feasible in an intraoperative motor symptom quantification. And additional potential for our pipeline and the sensor may be assisting in DBS surgical decision real time, such as identifying the sweet spot for the electrode placement or optimizing the electrical stimulation settings, such as the frequency or the voltage of the DBS. However, at this point, we need extensive validation on running our pipeline across multiple patients so that our method can be generalized not only in the baseline PD conditions as we see in this study, but also in stimulation conditions with varying DBS settings as well. Thank you so much for hearing my talk.